Hi, good morning, everyone, and welcome to Breakfast at FOM. I'm Jaya from the Endocrine Unit, Department of Medicine, and we have an exciting talk this morning where we are going to focus into obesity. So you would all may have come across the fact that 4th of March was actually observed as World Obesity Day. It's a day to remind us and to be aware of the multiple problems that come along with obesity. So whether you are a gastroenterologist, a cardiologist, or orthopedic surgeon, or even a gynecologist, I think you cannot run away from the fact that the problem of overweight and obesity actually affects your patients, even in the diseases that you manage, whether it could be osteoarthritis, it could be PCOS, it could be fatty liver. Obesity really spans across the board. So it's really everybody's business. And it's important for all of us to be updated on what the new updates are in obesity. So today is going to be a little bit different because you and I all have seen in clinics some patients who actually are quite obese, but actually do not suffer from very bad metabolic or other complications. So we're actually going to focus on that entity today. What has been coined or what's been intriguing in the sense that it's been said that there's an entity of metabolically healthy obese individuals. So to shed light on this morning, it's my pleasure to introduce my colleague, Dr. Quan Hziung. He is a medical lecturer with the medical department in the endocrine unit, and he is an endocrinologist. And he's very, very passionate about obesity management, and he's very well published. And he's going to take us through deciphering what this metabolically healthy obesity is all about, and how we can actually, use this in our day-to-day clinical practice. So there's only one session today, and we have until 8:30 in the morning. So do key in your questions into the Q&A box so that I can bring it up to Dr. Lim and we can discuss it later in the morning. So Dr. Lim, I'll hand over the Zoom to you.
Thank you, Prof. Jaya. Thanks for the kind introduction. And also, I think thanks, Prof. Jaya, for eloquently introducing the topic today. And I think it's very timely that we discuss about obesity in our hospital as well as in the country, given that the World Obesity Day was last month, right? Okay, so the title of my topic is actually deciphering the relationships between anthropometry, body composition, and metabolic dysfunction using the metabolically healthy obesity model. Now, it might sound like a mouthful, all right, but I think I will slowly take you through the whole concept of metabolically healthy obesity and why we title our research our topic this way, right? So we all know that there is a growing problem of obesity in Malaysia. It's no longer news to us. We know that Malaysians are getting fatter, and from the National Health and Mobility Survey data from 2011 to 2023, our numbers of Malaysians with obesity has been steadily growing, and up to 2023, we are standing at 54.4% of Malaysian adults who are living with obesity with a BMI of more than 25. And now these numbers is big, but even if you compare it at the global level, this is based on the World Obesity Atlas by the World Obesity Federation. We are actually 30 years ahead of the curve, about 25 years ahead of the curve, where the projected global rate of obesity is 54% by 2050. So Malaysians are rarely leading the world, but this is one of the things that we shouldn't be proud about for actually being ahead of the curve. Now, we also believe that one of the reasons for the inertia with dealing this problem with obesity is also because of this idea or this concept of what we call metabolically healthy obesity. So I think this idea is not new, but it has been coined in research literature for about 20 to 30 years now, where people believe that certain people with raised body mass index, but they do not exhibit overt metabolic complications of obesity. And I'm sure you and I, we've all thought about this concept. Like, we do have so many people walking around with high BMI, but just who is it that actually is quote unquote unhealthy, right? So remember that obesity does affect the body through systemically. So it's not just your metabolic health, your musculoskeletal health, your cardiovascular health, everything is also affected. So metabolically healthy obesity is only just one part of the concept, or what we call the healthy obese. But really, what are the factors that differentiate between people who are metabolically healthy versus who are metabolically unhealthy? So researchers have been very curious about these questions and have actually published multiple research that looked at the factors that differentiated the MHO and the MUO group. And these include factors such as increasing age, male sex, having unhealthy fat deposition patterns, and this may be genetically predetermined, physical activity patterns, diet, of course, and as well as gut microbiota. So what is the prevalence of metabolically healthy obesity? Like, just how many percent of people who have raised BMI are quote unquote healthy or metabolically healthy? So the definitions of metabolically healthy obesity varies very widely throughout different publications in different parts of the world, as well as different BMI thresholds that are adopted in different parts of the world. At any rate, the prevalence of MHO ranges around 10 to 30%. However, as of now, we still do not really know the Malaysian adult prevalence of MHO. But really, is it very important for us to know MHO, or how many percent of Malaysian adults are actually quote unquote mentally healthy when they're obese? I mean, it is arguable because there are research that's showing that people who are mentally healthy obese are not necessarily healthier compared to people who are lean and healthy. However, the concept of metabolically healthy obesity does offer an avenue to stratify and study the underlying phenotypic complexities of obesity as a disease. Now, we all know that the BMI is not a perfect metric to define obesity, and there are very many different cutoff points to define overweight obesity in different populations. As you can see in this figure here on the left, the global WHO cutoff for definition of overweight is actually 25 and obesity would be 30. But because Asian populations tend to develop complications at a lower BMI, we do have an overall lower BMI cutoff to define overweight at 23 and obese at 25 based on the Asian BMI cutoff points. However, in Malaysia, based on our latest clinical practice guidelines, our definition of overweight is 23 kilograms per square above, but the obesity is defined as 27.5 kilograms per square and above. Now, these cutoff points are taken just based on different population-based risk factors that are defined by our public health researchers. However, we also know that BMI does not discriminate body composition and fat distribution. And even people with normal ranges of BMI may have excess adiposity, and that even has been coined as what they call as normal weight obesity. So actually, all in all, obesity really is a very complex disease and very hard to define. Therefore, researchers have come up with different anthropometric determinants of adiposity to start looking at what excess fat rather than excess weight and excess mass as a better representation of an unhealthy state. So because we can't go around doing body fat percentage for everybody, because that would be very expensive. So there are other anthropometric determinants such as waist circumference, waist to height ratio, waist to hip ratio, and even neck circumference that are able to represent excess adiposity as a cheaper method of measurement at a larger scale. Of course, a measurement of body fat percentage and segmental fat via more advanced measurement methods such as bioimpedance analysis or even CT scan or MRI. Those are, of course, the more perfect, better accurate measures of adiposity. So we did this research basically we set out to actually look at the proportion of metabolically healthy obesity and metabolically unhealthy obesity among Malaysian adults with high BMI. And then we also wanted to examine the relationships between anthropometric measurements, body composition, and metabolic health in our population. And from there, we wanted to look at the factors in our population that predispose to be metabolically healthy, unhealthy obese, focusing on three main aspects, i.e. socio-demographic factors, the anthropometric factors, as well as body composition. So you may or may not be aware about this study that was done in 2023. So we did advertise this in the hospital email chain and recruited people with overweight, BMI 23 and above, age 18 to 65, with no chronic medical disorders, i.e. apparently healthy at baseline. So because this was done in UMMC, this majority of our participants were healthcare workers. We had a total of 302 respondents came to join our study, but we did exclude 4 of them because of various reasons of exclusion criteria, i.e. if they have received formal weight loss interventions, such as taking anti-obesity medications already, if they have overt endocrine disorders, or if they're taking any regular medications or supplements, or if they were recently unwell. So we recruited about 298 patients, and we had one participant who had incomplete data. So we had a final number of 297. So during the data collection, we collected a fasting blood sample for the blood glucose, HbA1c, and lipid profile to profile their metabolic health. We looked at their sociodemographics via a self-administered questionnaire. We did the anthropometric measurements, blood pressure, height, weight, waist circumference, hip circumference, and neck circumference. Finally, we did a bioimpedance analysis and to show us their body composition. So this is how we classified MHO versus MUO. We took the Malaysian cutoff of overweight at 23 kilograms per meter squared above as overweight obesity. And if the participants had any of the following picked up during the data collection, if they have any elevated blood pressure, elevated fasting blood glucose, high HbA1c, high fasting triglyceride or low HDL, or any evidence of previous diagnosis of cardiovascular disease. So any of these criteria, they will be classified as metabolic unhealthy obese. And if they do not meet any of the criteria, then they will be metabolic healthy obese. So it is a mutually exclusive criteria. We then did some derivative calculations based on our metrics that we collected, including the BMI, waist to hip ratio, waist to height ratio, and we also calculated the triglyceride glucose index. The triglyceride glucose index has been compared to different measures of insulin resistance and has been validated against even the homeostasis model assessment of insulin resistance, or the HOMA-IR, and even the hypoglycemic euglycemic clamps, to show that it is actually a good measure of insulin resistance. So these were our results. We found that in our population, 2/3 of people with BMI 23 and above are already metabolically unhealthy, meaning that had at least one metabolic disturbance if they have raised BMI. And if we took the different BMI cutoff points, as illustrated just now, so at different cutoff points, at a higher BMI cutoff points, the proportion of the metabolically unhealthy obese would only increase as expected. And when we look at the number of metabolic abnormalities, so among the MUO group, majority had at least one metabolic abnormality. And when we broke it down, we found that hypertension or elevated blood pressure was the most common disorder, followed by dyslipidemia and dysglycemia. And when we looked at the sociodemographic profiles of people with MHO versus MUO, we found that apart from gender, being a male, the other sociodemographic factors such as ethnicity, occupation, or education levels were not different between the MHO and MUO group. Now, you may notice that majority of our participants here are Malays, and we have a large number of nurses, and we had a large number of women in our study. But so therefore, we weren't really we weren't adequately powered to look at inter-ethnicity differences. But we do believe that if we had a larger number of Chinese and Indian participants, we may have seen some differences in our ethnicity distribution. Now, when we looked at the anthropometric measurements of metabolic health, we found that people with metabolically unhealthy obese had overall higher measures of anthropometry, and these include all the BMI, waist circumference, hip circumference, all the waist-hip ratio, waist-height ratio, and neck circumference, and it is not surprising at all. And we looked what was surprising is when we looked at the body composition and metabolic health, is that the metabolically unhealthy group had overall higher measures of both fat mass as well as lean mass, but body fat percentage was not significantly different between the two. And we look at the p-values here. So the BIA machine actually is able to give us a body fat mass as well as fat-free mass, which is defined as lean mass. And we found that the MUO group had overall both high fat mass as well as lean mass. This was counterintuitive because we did believe that people with quote-unquote medically healthy obesity would have had higher lean mass instead. Then we try to look at the correlations between the different body composition metrics as well as the anthropometry. So this may look very complicated, but let me just guide you through this diagram here. So basically, we are looking at the correlation metrics between the body composition as well as anthropometry, and this is the matrix. So the greener the box is, the more positive the correlation is, the redder it is, the lesser it is, and the red one will be negative correlation. And we look at the fat mass, it was actually strongly correlated with different measures such as BMI, waist circumference, hip circumference, and your waist height ratio. But it was not correlated very well with your neck circumference and your waist hip ratio. We also found that the fat-free mass or the lean mass had a stronger correlation with your neck circumference and your waist hip ratio rather than the BMI, waist circumference, hip circumference, and waist height ratio. And when you looked at the triglyceride glucose index, which is the measurement of insulin resistance, it's stronger correlation with neck circumference and the fat-free mass as compared to your BMI, waist circumference, hip circumference, and fat mass. So what does this tell us? So when we plotted a graph of the neck circumference and insulin resistance, we did find a nice, a moderate correlation of 0.44. Then we tried to do a mediation analysis where we looked at the different, we divided the body into 3 different segments, the upper, middle, and the lower body segment. And we looked at how much did the anthropometry contribute to being metabolically unhealthy obese that is mediated by the body composition metrics. So if we look at the upper body, we took the neck circumference as a surrogate measurement of the upper body mass. So we did know that we found that neck circumference contributed towards metabolically unhealthy obesity, and this was mediated by both the upper limb fat mass as well as the fat-free mass. And we look at the trunk, whereby the waist circumference was a surrogate measure. We found that the effect of the waist circumference on metabolically unhealthy obesity was mediated by truncal fat mass and fat-free mass, similarly to the upper body. Whereas when you look at the lower body, the effect of the hip circumference as a surrogate measure on metabolically unhealthy obesity was mediated by lower limb fat-free mass, but not mediated by fat mass. And when we did multiple logistic regression on the anthropometric and body composition factors to look at what predicted unhealthy obesity, we found that at the base model, higher age as well as male sex increase the likelihood of being metabolically unhealthy obese. And when adjusted for that, body fat percentage as well as lower limb fat-free mass remain also statistically significant. However, when we inserted the anthropometric measurements into the model, we found that neck circumference remained as the only independent predictor of metabolically unhealthy obesity when adjusted for other anthropometric measurements, as well as the body composition metrics, sex, and age. And finally, when we added the triglyceride glucose index, which is a measure of insulin resistance, into the model, everything else was not statistically significant. So because of the interesting finding of high neck circumference being a significant predictor of metabolically unhealthy obese status, we did a ROC curve analysis to determine what was the threshold for us to decide whether it is an unhealthy obese. So in women, a measure of 32.5 centimeter, and in men, a measure of 38.4 centimeter of neck circumference would be able to predict MUO status by a moderate sensitivity and specificity. So we believe we were the first to report the Malaysian prevalence of MHO and MUO based on a standardized definition. There were previous studies that tried to look at this breakdown of Malaysian people with obesity, and based on the Malaysian NHMS data, 23.7% of people with obesity with BMI more than 30 have obese but disease-free in this publication, but they could not accurately classify MHO or MUO status because they didn't have the triglyceride or HDL-C data. In a separate paper that looked at Malaysian school children with obesity, they found that the prevalence of MHO was about 30.1%, just not that different from our findings. However, medical literature is very strong about MHO is just really a transitory status because people can transition between MHO and MUO over time. As shown in our results as well, when you have an increase, when your age increases, the likelihood of you transitioning from MHO to MUO is also increased. People with MHO also have overall higher cardiovascular risk when compared to lean individuals. Therefore, it is important to keep in mind that the MHO concept rather is more useful as a risk stratification tool instead, rather than something that you can tell someone, your patient with overweight obesity, that it's okay to stay at this elevated adiposity or BMI. When we look at the anthropometry, body composition, and metabolic health relationships, we found that overall increased body mass is associated with MUO status. Whereas we look at the expansion of the fat-free mass, which was measured by the neck circumference and the waist-hip ratio, contributes to MUO, likely explained by increased insulin resistance. Whereas the fat mass was better represented by body mass index, waist circumference, hip circumference, and waist height ratio. So this tells us that the different anthropometric measurements tells us different information based on the patient's metabolic health. So previous large-scale data in Canada, for example, also did see that metabolic syndrome, the prevalence of metabolic syndrome would rise with increasing quartiles of absolute fat-free mass. And increased appendicular fat-free mass is independently associated with HOMA-IR, if found in another study. When we compared our measures of a neck circumference to other studies, we did find that our threshold of 32.5 cm and 38.4 cm for men and for women and men respectively was similar to another study that looked at that compared neck circumference with an MRI measured visceral adiposity. We do believe that the neck circumference is a better measurement of than waist circumference or hip circumference with patients with extremes of obesity, where the neck circumference would then come off as a better measurement. And this also apply in people who may have larger waist circumference due to other reasons such as ascites, as well as people in as well as pregnant women. So the reason is being that the neck is an ectopic fat depot that is associated with insulin resistance and has been widely reported that the increased neck circumference is associated with increased cardiovascular risk. So our research also concurs with this recent publication in the Lancet and Diabetes Endocrinology in January 2025 that sought to redefine the concept of clinical obesity. So there has been a lot of debate about how should we really define obesity, and is obesity just a risk factor or is it a disease state? So we find that this publication elegantly laid out that how as clinicians and as policymakers we should be starting to define obesity as an illness. Specifically, clinical obesity should be defined as a chronic illness or a disease state that results in the alterations in the function of organs and the whole organism that is directly induced by excess adiposity, independent of the presence of other adiposity-related diseases. Now, when we have someone with an elevated body weight or BMI, as mentioned just now, that may not necessarily correlate with adiposity. For example, people with athletes may have a higher body mass and may have a higher lean mass compared to fat mass, and they may not have excess adiposity. Then we should then not classify them as obese. But you have a high BMI, but you have a high measure of fat mass, such as using a measurement, surrogate measurement of adiposity, such as waist circumference or waist hip ratio, or even neck circumference as shown in our study, or other measures such as your PIA machine. You have high BMI, high fat mass, then they should then be classified as obese. But then you then need to assess them for evidence of any clinical dysfunction, i.e. clinical obesity. So if they have any obesity-related organ dysfunctions, if they have any limitations of their daily activities or both, if they do have that, we should define them as clinically obese. If they don't have that, then they may be preclinical obese. It's important to note that the obesity can lead to life-altering or life-threatening complications, as we may all be aware, and the organ dysfunctions and complications can arise at different levels of adiposity, and the severity of the symptoms and complications may vary between individuals at any given BMI, as illustrated in our study. And not everyone is susceptible to the same symptoms and complications. Now, metabolically healthy obesity only exists as one part of the whole systems-wide of complications of obesity, which may affect the whole body, including the CNS, respiratory system, cardiovascular, reproductive system, musculoskeletal system, etc. So what we're looking at here is really just the metabolic health, and we did not look at other factors, other complications of obesity. So the strengths and limitations of our study, we believe we were the first study to look at MHO among Malaysian adults. We identified at-risk phenotypes among people with obesity in our local population. We do admit sampling bias. We did omit people with pre-existing metabolic conditions. Therefore, we are likely underestimating the true prevalence of metabolically unhealthy obesity in our population. And this was mainly a single center study. We had mainly healthcare workers and were Malay predominant, and there were likely unaccounted factors such as of metabolic health, such as diet and physical activity, which were not included in this analysis. And we were not powered for inter-ethnic comparison, which I think is very important in our population. So in conclusion, at least 2/3 of Malaysian adults with raised BMI already have high-risk adiposity patterns. Now, both fat mass and fat-free mass expansion in people with obesity may contribute to MUO. In terms of clinical implication, we believe that neck circumference should be incorporated in routine health screens. And there is an urgent need to define clinical obesity as a disease state amongst all clinicians as well as policymakers. So my research was actually funded by Department of Medicine Research Grant, and thank you. I thank the department for this opportunity to carry out this research, which was part of my endocrinology fellowship training. With that, I thank you very much, and I welcome any questions.
Thank you very much, Dr. Lim. I think congratulations on your work. I think it's really something that's very important and was begging to be done in our population for some time. So I think for those of you who have tuned in, please do keep your questions. You can type it into the Q&A box, and I can bring it up. So I think there's a question here with regards to, I think maybe I'll just expand a little bit on the question. I think you did mention clearly that in your study, Quan Hziung, that you actually found neck circumference to be a good surrogate marker of unhealthy obesity. But I mean, that in the past has not picked up as well as sort of as powerful as hip circumference or waist to hip ratio, which we are a bit more familiar in terms of clinical practice use. What are the reasons for that, you think? And how is it going to go forward? I mean, do you think neck circumference is something that's going to be implemented in regular clinical practice? Should it be? And there's also another practical questions about landmarks. I think the attendee is trying to ask exactly where along the neck should you be measuring?
Right. Okay. So we did to answer the second question first, we followed the standardized WHO guidelines. So if you look at if you look up, there's a guideline by WHO on where to measure your neck circumference, your hip circumference, your waist circumference. So I can't remember exactly the definition exactly where, but we followed it. So I think it's somewhere midpoint in the neck. So of course you need to also make sure that this patient doesn't have any neck mass or like goiter or whatnot. So which was not we didn't find that in the participants. So there is a standardized measurement of how the neck circumference should be measured. And to answer the first question, so I do believe that in extremes of obesity, the waist circumference and the hip circumference when would be less useful because I believe that during the I mean if you divide people into if you look at them as a whole, when they start becoming unhealthy at a lower BMI, so they tend to have higher risk of developing metabolic unhealth, metabolic dysfunction with very slight or relatively slight enlargements of waist and hip circumference. Those are people who have already been unhealthy at a lower BMI already, whereas people who are quote unquote protected are able to have a higher fat expansion and able to achieve higher BMI without metabolically unhealthy, being metabolically unhealthy. And then when they have the expansion over the neck, then it will be that will be an additional risk factor to then be becoming metabolically unhealthy. So I do believe at extremes of higher extremes of BMI, the neck circumference is a better measurement to differentiate between those who are quote unquote healthy or unhealthy. It's not saying again that not that the people who are quote unquote medically healthy are actually healthy. So it really is just more of a stratification tool. Additionally, is an additional risk to have a high neck circumference compared to your high waist and hip circumference.
Yeah, thanks, Kwanzaa. I think at a personal level, I'm quite glad that my neck circumference actually falls much better than my hip circumference, I think. So I think along the line, I mean, you did mention, I mean, of course, I think the intriguing thing that, that term of metabolically healthy obesity, I mean, if someone is found to be obese and does not have any sort of metabolic syndrome or clinical complications, um, do you think they are safe in that sense? And what is as a clinician, how often would you screen them for complications, in general clinical practice?
I
A quick
think
answer, because we have quite a number of questions coming for
Yeah,
you.
I think I've mentioned multiple times that again that this study doesn't tell you that MHO equals a healthy state. So it is really a misnomer, and there are a lot of people who are arguing against using this term because we really aren't really healthy when you have a raised BMI or raised adiposity. So you should still treat them as a high risk compared to people who are lean, and raised adiposity really is really as a higher risk, and screen them regularly as you would as is our current recommendations.
Yeah, okay. So
Yeah.
there's also a question, Kwan Jong, about, this whole issue about, doctors are quite comfortable addressing diabetes, cardiovascular disease, arthritis, or whatever it is. But they do feel, sometimes that patients may, we might feel that we're stigmatizing them if we do, coin the term obesity or, overweight. So how do you tackle this problem? Because, I mean, there's a question here about, people may perceive it to be body shaming in a way.
Yeah,
Um,
I think
yeah,
we Yeah, thanks, Prof. Jaya. So I think that's a great question. That's a huge issue that we all should address as a clinical community. Is that we should look at obesity as a disease, and we're not talking when we're talking really as a disease. We are not focusing on the person itself, but really focusing on the disease. You do not shame a person for having diabetes, or shame a person for having hypertension, or even cardiovascular disease, or depression, etc. So a disease is a disease state where there is a dysfunction in the body, and we as clinicians will recognize it as a pathological state, rather than shaming them as in terms of lack of behavioral control, etc. So that is a different aspect altogether, where that's actually looking at your stigma of having towards people with raised BMI. So when you look at someone, when you see someone as a disease, then you need to focus on treating the disease as how you would treat someone with cardiovascular disease, etc.
yeah, I
So
mean, I
yeah,
totally agree with you, Kwan Jeong. I think overall, I think the whole medical field needs to sort of relabel and reclassify obesity itself, because I mean, only up to the National Health and Morbidity Survey only last year actually included obesity as an NCD in our country, but still. For people who are going for obesity treatment, whether be it anti-obesity medications or even bariatric surgery, many a times it's not easy to find easy access for insurance coverage or any kind of reimbursement. So I think, I mean, around the world it is similar in that sense. So there's still a lot of, I think, efforts that need to be put in with regards to that, because I think treating obesity probably has the best amount of rewards or returns, in terms of improving general health versus treating just diabetes or putting a stent in for your heart, isn't it? Or even treating sleep apnea. So there was a question about sleep apnea. Maybe you can comment about that. I think Prof. Tengku Sarah is asking. Yeah,
Thanks.
so she's also commented to say that, it's worse, about the body shaming. It's worse if you're trying to tell your friend or your relative. It could be your own sibling or uncle or auntie or whoever it is, or even child, maybe. It's worse. And if you're not their doctor, it's even worse, she's saying. Yeah, I
Yeah,
totally agree with you, Prof. Yeah.
I
So
agree
a
with
bit
you, Prof.
about sleep. Yeah.
Yeah,
Kuan Song?
yeah. Thanks, Prof. Sarah, for that question. So, we do believe that probably could be a contributing factor to what we are seeing here, given the neck circumference, high neck circumference slightly contributes to OSA. Unfortunately, we did not collect data on sleep quality or any history of OSA, history suggestive OSA in our study. So that would be interesting to look at, and I think should be studied in the future. And also to address your issue about stigma, I do believe that we should recognize that obesity is really not just a single person's fault. We shouldn't really fault the person that, oh, you're obese. When you're looking at the entire nation, the entire trend of the nation is going towards obese. Really, something is wrong with our system per se. So it's a whole environment, multi-systemic, multifaceted aspects that's actually driving the entire community, the entire country to become more and more obese. So if we reflect upon that, then we know that really we shouldn't be blaming individuals. The whole environment, obesogenic environment, food availability, then we can go on for hours to talk about the other factors that really drives obesity. So when we think about it, obesity as a whole, we should really look at that as a whole rather than blaming the individual per se.
Manjung, there's just a last question before we wrap up about your plans on long-term follow-up of this cohort, or, in terms of validating uh,
Yeah,
neck circumference, or even the long-term follow-up of those who were somewhat healthy.
yeah. We did keep the contact of this cohort of people, and we do plan to actually have a long-term follow-up and see whether there's any transformations in their metabolic health over time. So that'll be interesting to look at. So the MHO, whether they become MUO or etc., and what the factors that determine that. So that'll be interesting to look at in our population.
Okay, Kwan Jeong, any last simple message for our listeners today? Because there was a comment to say that there were a lot of information. So we do recognize that obesity is quite complex, and I think Kwan Jeong has done a lot in terms of looking at this aspect. And congratulations again, Kwan Jeong. And any last words, the take-home point?
So I think take home point is really just to view obesity as a disease, not a fault to a person, not a shame, and not just a risk factor. Obesity is a disease when it causes dysfunction. All right, and start screening people for any obesity related dysfunction. And my study is only a very small part of how we can screen and stratify people with obesity.
Thank you very
Thank
much,
you very
Kwan Jeong.
much.
Yeah, although
Very
you
much.
don't say small, but I think it made a big impact.
Thank you
Thank you
very
very
much.
much. So thank you very much, everyone, all the listeners. Great work, and have a productive and enjoyable day ahead. Thank you
Thank
very much.
you.
Selamat Hari Raya to those who are celebrating.
Thank you.